The Epilepsy Foundation is pleased to share with you an educational webinar providing an overview of rescue therapies in epilepsy. The mission of the Epilepsy Foundation is to lead the fight to overcome the challenges of living with epilepsy and to accelerate therapies to stop seizures, find cures, and save lives. My name is Dr. Elaine Kyriakopoulos, and I would like to extend a warm welcome to everyone who has joined us this evening. It's wonderful to have you all here with us for tonight's learning. I'd like to just take a moment to review with you the format for tonight's webinar. Throughout the presentation, all phone lines will be muted. However, we'd like to encourage everyone to go ahead and submit their questions at any time during the webinar. To do so, type your questions into the question window on the GoToWebinar panel and click Send. We'll read your questions aloud and address them during the question and answer portion of the webinar. Please try to keep your questions general in nature, as the webinar is intended for educational purposes. This webinar does not take the place of individual medical advice. This webinar will be recorded and available for viewing and listening on epilepsy.com. Epilepsy affects approximately 3.5 million Americans, and anyone can have epilepsy. The way each person is impacted by epilepsy will vary, and the choice of therapy used to control seizures and limit risks from seizures is always individualized. In general, the first line of therapy for epilepsy involves the use of anti-seizure medications to prevent seizures. Anti-seizure medication that is scheduled and taken daily is what we refer to as preventative therapy. Tonight's webinar will be reviewing another category of medical therapy in epilepsy, which is commonly referred to as rescue therapy. Let's take a moment to review, in general, how anti-seizure medications work. We know anti-seizure medicines work by suppressing the symptom of epilepsy, seizures. They do not treat the underlying causes of epilepsy or cure epilepsy, but simply work by stopping the abnormal electrical activity in the brain that gives rise to a seizure. There are several different ways in which anti-seizure medicines stop seizures from happening. They work on specific targets in the brain, and although the way these medicines work is not fully understood, we know that anti-seizure medicines can affect the neurotransmitters that are responsible for sending messages, or attach themselves to the surface of brain cells and alter their electrical activity to prevent a seizure from happening. Clinical studies have helped us to better understand how effective medications are at preventing seizures. We know that for about 2/3 of patients, it's possible to achieve good seizure control with medications. And for this group of people, their epilepsy can generally be described as uncomplicated. But for about 1/3 of people, anti-seizure medication is not able to control their seizures. And for this group, epilepsy can be disabling. Frequent and unpredictable seizures bring risks and interfere with day-to-day life. Medication side effects can limit learning or activities. And for many, the presence of ongoing seizure activity in the brain can have long-term effects as well. Tonight's webinar is going to share with you information about medical therapy used to stop seizures, referred to as rescue therapy. A simple definition of the word rescue is the act of saving from danger or distress. And indeed, when we talk about rescue therapy in epilepsy, the goal is to introduce a treatment that will limit the danger and distress that can result from prolonged or repeated seizures. The rescue medicines you will learn about tonight are a class or category of medicines called benzodiazepines. Benzodiazepines are one of the most widely prescribed drugs in the United States, as they have the ability to help treat a number of both neurologic and psychiatric diseases. They were first developed in 1955 and about a decade later were used to treat status epilepticus, prolonged or repeat seizure activity, which is considered a seizure emergency. What was found over time is that benzodiazepines are potent anticonvulsants. They work well to stop seizures, and they do so by increasing or enhancing the effectiveness of a neurotransmitter in the brain called GABA. GABA, we know, has the ability to decrease electrical activity in the brain responsible for seizures. We are so fortunate to have with us tonight Dr. Scott Perry and Patty Schaefer, who will share more with you about the use of benzodiazepines as rescue therapies in epilepsy. I'm going to take just a few moments to introduce our guest speakers to you. Dr. Scott Perry at the notorious EEG is the Medical Director of Neurology and the Genetic Epilepsy Clinic, as well as co-director of the Jane and John Justin Neurosciences Center at Cook Children's Medical Center in Fort Worth, Texas. He completed his MD at the University of Mississippi School of Medicine and his general pediatrics and child neurology training at Emory University. He completed a clinical neurophysiology fellowship at Miami Children's Hospital before joining Cook Children's in 2009. His clinical and research interests include the use of epilepsy surgery for the treatment of intractable childhood epilepsy and the evaluation and treatment of genetic epilepsy syndromes. Thanks for sharing your time with us this evening, Dr. Perry. Patricia Osborne Schaefer is the Senior Director for Health Information and Resources and the Associate Editor of Epilepsy.com for the Epilepsy Foundation. She worked for many years as an epilepsy clinical nurse specialist at the Comprehensive Epilepsy Center at the Beth Israel Deaconess Medical Center in Boston, Massachusetts. Patty received her undergraduate education at the University of Vermont and a graduate degree in neuroscience nursing from the University of Washington in Seattle. She is a past member and past chair of the Epilepsy Foundation's Professional Advisory Board, a past member of the Board of Directors of the Epilepsy Foundation, and a long-term member of the Professional Advisory Board of New England. She has served on the American Epilepsy Society Board of Directors and numerous committees and work groups. Thanks for being here, Patty. Noted here are speaker disclosures for this evening. And with that, I'll now turn things over to my colleague, Patty Schaefer.
Thank you very much, Dr. Kyriakopoulos. So tonight during this session, we'd like to have everyone gain a better understanding of rescue therapies for seizures so that you can feel more confident about talking about the impact of seizures and clusters with your family and with your healthcare team. And by feeling more confident in talking about those issues, you'll be better prepared to know what to ask your care team about rescue therapies and seizure action plans. Next slide. So why talk about rescue therapies? Well, as Dr. Kyriakopoulos already said, repeated seizures or long seizures are dangerous. It can increase the risk of injury, and in some cases, if seizures last too long and you end up in status epilepticus, which is the emergency situation, people can die from that. And, while most people like to think that, epilepsy's not a serious disorder, we know that it is, and this is clearly one of those scenarios that, there are ways to prevent it, and that's why we really want to talk with you tonight about that. We also know that therapies exist that can help stop seizures, and that we have two rescue therapies already approved by the FDA, and we have new ones coming. And these are designed to be used outside of the hospital to abort seizures, to prevent seizures from going into status epilepticus, prevent emergency room visits or hospitalizations. But we also know that healthcare professionals, people with epilepsy and families have different views and understandings about rescue therapies, thus the need to really talk more about this. Next slide. So what is the rescue therapy? Well, the simple definition right now is a medication or therapy that's used to stop seizures or a cluster of seizures and prevent a seizure emergency. Again, as I said, designed to be used by non-medical people outside of a hospital setting. And what we want to talk about during this is, the difficulties that so many people have in really understanding what this is, because we don't have a common lexicon. Next slide. Right? So even just, there's a lot of discrepancies about how often rescue therapies are used. One study that was done in the past few years at an adult epilepsy center followed 300 people over a year. And these are people that primarily had uncontrolled epilepsy, and only 1 in 10 people had a prescription for a rescue medicine at the start of the study, despite 28% of them had what we call active epilepsy, so they're diagnosed with epilepsy and being treated for that, and they also had a history of clusters of seizures. And then over the course of that year, during the study, only 26 people, which was 11% of the total, actually used the rescue medicine. So one of the big take-home points was they felt that rescue therapies were being underutilized, that they could benefit a lot more people. And that went along with the conclusion of a prior study that was a retrospective, or it looked at people's medical history in the past and came up with the same conclusion, that it's not being used as often as it could. Next slide. So to get at a more current understanding, at the Epilepsy Foundation, we did a survey earlier this year in the spring. It was through epilepsy.com, and 397 people responded. 2/3 of the people were family members of children with epilepsy or of adults with epilepsy, and 1/3 with epilepsy. And it reflects experiences for children or for adults up to middle age. So here we see that rescue therapies tend to be used by many more. So there's 69% that had a prior use of rescue therapy. So at some point in the past they had used them. And then when asked, are they using them now, 92% had been using them now. So that's much different than the prior studies. So when I first think about this, I don't think it's necessarily underutilized, but we don't know that how many people could benefit from it. But even despite, so many people saying that they are using a rescue medicine, 1/3 of the people said no one's actually given them any information about them. So there is a huge information gap as well. Next slide. So now we stop to think about when are rescue therapies. So again, in this sample, about 50% said their seizures were controlled, and about 50% were not controlled. Regardless of whether seizures were controlled, the majority of people were afraid or worried about having another seizure. And that also leads into when should rescue therapies use. So we already mentioned it could be for clusters of seizures when someone's having too many seizures or too long seizures. But if a person's able to identify a period which might place them at greater risk of having a seizure, a rescue therapy could potentially be used in that case. And here we had 40 to 50% who reported that seizures could occur predictably at specific times of day or night, or associated with certain situations. So maybe examples of when they're in high stress situations or when they're traveling. And the biggest period over, I think it looks like it was 55 to 58%, is that when they're sick or missing medicines, so that they knew during those times, those are easily identified triggers for them, so that they would use a rescue therapy in those situations. Next slide. So on this slide here, what we see is that, so in this question asked what people call their clusters and when they would use the rescue therapies. And we did this kind of word analysis to try to look at the most common names. And clearly what you can see is that those in the red, cluster seizures or long seizures or prolonged seizures or repeated seizures, were the most common ones. Next slide. But we still had about a third of people who used used terms such as multiple seizures or events or repeated seizures to describe when they were using a rescue therapy. But look down on the bottom. A lot of people just used words like bad day, bad seizures, breakthrough seizures, risky day. So the terms that people with epilepsy and families use are kind of all over the map when they think about when they should use a rescue therapy. Next slide. So now, do we know what cluster seizures mean to people? Well, first we say, how often do clusters happen? And in this study from this adult epilepsy center, they found that about 40% of people with active epilepsy had clusters, but they define clusters as having more than 2 seizures in 6 hours. Yet another study that tracked people recording seizures in a seizure diary found that about 29% of people had them. They defined it as 3 in over 24 hours. Yet another study followed people over a couple years with new onset epilepsy, found about the same number. About a third of people, even with new onset epilepsy, had cluster seizures. So there's not a real good understanding of when or how many people might be affected by cluster seizures. And we don't obviously have a consistent definition. So in these cases, in studies, they focused in on the number of seizures, and it was very variable in terms of what they define clusters. Next slide. So I've done a couple projects over the past few years with some colleagues, and we tried to get an understanding of what people with epilepsy and families say about rescue therapies and about clusters. Now, these data on this slide refers particularly to cluster seizures. And what we saw was that we analyzed thousands of posts on epilepsy.com, so social media posts of people writing about periods of increased seizures or cluster seizures or when they might use a rescue therapy. And one of the other projects looked at interviews of about 30 to 40 people. And in both cases, we had similar results, that for people with epilepsy and families, clusters were an experience. And they thought about this in terms of how it impacted them. So a cluster was not necessarily the number of seizures, but how did it affect their day? Did it leave them exhausted so that they couldn't do anything? Did they have to leave work or school? What impact did it have on their family member? So it was much more of the impact on their life, and also the emotions were tied to it. So epilepsy or clusters were clearly a much more of an emotional experience. For many people, clusters were seen as a unique or different type of seizures, so that they were aware of when their seizures were typical, the seizures that occurred singly, but they could identify clearly that what was different for them, and this was going to result in a cluster or result in a bad day and have some big impact on their day. The number of seizures, extremely variable. For some people, a cluster could be many a day. For others, it might be when 2 or 3 seizures clustered over a few days, such as for a woman who might have their menstrual period, or for someone who came down sick and they had that cluster of a few seizures at a time. People also reported being very confused about how clusters are diagnosed and when they should use their medicine. So it kind of echoes what I said earlier, that there's a lot of confusion about clusters. They also reported feeling not believed by their providers. So when they tried to talk about clusters and say how many they had or how it affected them, they felt like they really weren't believed, or it wasn't taken seriously and acted upon. So as a result, people really stressed that they wanted information on figuring out what they could do to identify when a cluster might happen, or steps that they could do to prevent it. So all the way from what can they do to prevent missing medications, or what could they do proactively if they were sick or they were traveling. So some of those self-management steps in managing their seizures. And they also stressed time and again that their providers didn't talk enough with them about rescue therapies about action plans, and how to prevent these kinds of emergency situations or potential emergencies. Next slide. So for people with epilepsy, and actually I would say for many of us, if you've got an emergency, it's like in case of emergency, break glass. Just like if you see a fire extinguisher, it says break glass. This is going to help you right away. And that's how people who are afraid of having a seizure or worry about that next one coming is they want something there in case of emergency. Next slide. Now, when we looked at perspectives of healthcare providers, though, they saw it very differently. Looking at their definitions or how they perceive seizure clusters, we looked at both what was published in the professional literature, but also some interviews with about 30 to 35 nurses and doctors. And in both projects, the professionals focused on the clinical aspects of seizures, the type of seizure it was, or the number of seizures over a period of time. They would consider consequences such as, did the seizure end up in status epilepticus? Did the person end up getting hospitalized? But they did not think about the personal impact the way people with epilepsy and their families did. When they were asked in interviews just specifically about the burden of seizures on people, they clearly differentiated seizures and felt that not all seizures are bad. And so the way people with epilepsy think about those bad days or bad seizures, that wasn't in the same nomenclature for the professionals. And in fact, if people had well-controlled seizures, even if they might be at risk or have high-risk times or triggers, many of the professionals described it, well, if they're well controlled, they're kind of out of sight, out of mind, and that's not said in a bad way at all. It's just that they think that the seizures are controlled and they don't need anything else, and they'll call me if they do, right? And physicians weren't concerned as much about the future possibility. Yet if you think back to that slide where I said 95% of people with epilepsy and families worried or were fearful of that next seizure, that's not on the same wavelength for the healthcare professionals. Nurses did express more concern about the impact of seizures on the individual and their families, and focused more on some of that, providing that practical support and how families and individuals could more proactively manage the seizures. Next slide. So this leaves us with gaps. This is the Grand Canyon, so a big gap. But we have gaps in our understanding about seizure clusters, our understanding about rescue therapies, the words that we use, and really everything about when to give them, what to call them, what to use. So I'd like to turn to Dr. Perry right now to talk us through what some of the rescue therapies are.
Thank you, Patty. So if we go to the next slide, I think if we could take anything from what we've heard from Patty in the introduction there, is that there's not going to be one size that fits all. So if you're looking for certain symptoms that equal a certain rescue plan, there's not going to be any kind of recipe that gives that to you. And so what we want to get across tonight is that this is a discussion to have with your healthcare provider to talk about when is that rescue needed, what rescue medication might be needed, and what is your seizure action plan. Every person with epilepsy might not need a rescue medication, but every person with epilepsy needs a seizure action plan. And so it's worth having that conversation. So what is a rescue therapy? It is an as-needed medication. So it's not something you're taking every day. It's something you're taking only in certain situations. And that situation will be defined between you and the provider of your health care. In general, as Patty said, we're going to use it to stop cluster seizures, or when a person has repeated seizures, or when people have seizures that last longer than usual, or maybe when the pattern of seizures differs, or in certain situations, say illnesses, for example, if you know you have a history of increasing seizures during an illness, maybe high-risk times like that. Next slide, please. So what are cluster seizures? Again, there's not going to be a definition that fits every person. Every person will really define their own definition of clusters for their unique epilepsy. But basically, it is more than one seizure over a certain period of time. In general, the seizures are recognized as distinct. So they're recognized as being different from the usual pattern of seizures that they have every day. Maybe there is a certain seizure type, maybe there's a certain aura, Maybe there's a certain feeling or conditions of the day that predict once a seizure occurs that subsequent seizures will occur later on, indicating that a seizure cluster will occur and a rescue medicine may be needed. Importantly, cluster seizures are seizures in which a person returns to their baseline state in between. And that really differentiates it from status epilepticus, which we're going to be talking about in the next slides. Next, please. So rescue therapies, when are they prescribed? I think this quote from Dr. Bucharter really sums it up, and the individual nature. So a seizure cluster of repetitive seizures is defined by the patient and the caregiver along with the provider in an individualized manner based upon not only seizure frequency, but the consequence of those seizures, how those seizures are tolerated, and then of course the known effects of whatever treatment we are using to stop that cluster. So each treatment will be unique. Next slide. So what is status epilepticus? There's two types of status epilepticus that you'll hear people talk about. The first is convulsive status epilepticus. And that is when a tonic-clonic seizure lasts longer than 5 minutes. That is when a person has multiple seizures and fails to recover consciousness in between, or with seizures that are convulsive lasting longer than 30 minutes. Next slide. Non-convulsive status is a little more difficult to define because that is defined as long or repeated absence seizures, which are really just periods of impaired awareness, or focal seizures where the only feature is impaired awareness. And basically you have a person who essentially has persistent confusion. They've never really returned to their baseline state. And sometimes it's really hard to separate what is continued seizure and what is really just the recovery period or the post-ictal period of the seizure. So there's no real consistent time frame to define non-convulsive status epilepticus, but prolonged periods of altered confusion without return to normal may represent this and be an emergent situation. Next slide. How common is status epilepticus? Fairly common. It has a high incidence for children less than 10 and for older adults. As you can see, between 50 and 150,000 Americans will have status epilepticus each year, and it's dangerous. You can die from status epilepticus, and the mortality is up to 3% in children and even higher, 30% in adults. Next slide. So specific instructions on when to use your therapies, as we said, will depend on the therapy and the person. And in the next slides, we're going to be talking about the variety of different therapies we have available. Next slide. So there are multiple ways rescue medicines can be given. They can be given rectally. They can be given into the nose or intranasally. They can be given into the mouth in two ways, sublingually, which is kind of under the tongue, or a buccal approach, which is just kind of in the side of the mouth. And then there are other approaches being developed. Next slide. When you think about what makes a good rescue medicine, what are the characteristics that we look for? Well, the first is that it be effective against all seizure types, or at least be effective at the seizure type that is most common in the person that needs the rescue medicine. We need the medicine to be safe at a usual therapeutic dose, right? Because if this is going to be given by people out in public who are not going to have the support of maybe a hospital system around them, we need it to be safe. We need it to be potent in a small volume, right? You don't want to have to give a lot of medicine to stop the seizure. You want a small amount to be adequate to stop it. It needs to be able to stop the seizure quickly. It needs to be very easy and safe to administer. Seizures are a scary thing. You don't want, a person that's helping in public, or a lay person already has enough stress with the seizure. So we need the rescue medicine to be very simple to administer so it can be done quickly, easily, and safely. It needs to work very quickly, so within minutes. And when it does work, we'd like it to continue working for a long duration of time so that we're not at risk of having this same emergency reemerge shortly thereafter. And finally, because this is meant to be given outside of a medical facility, we need it to have few or no monitoring requirements, right? We don't want to have to be monitoring oxygen levels and the breathing. We want these to be safe things that be given at home and you can feel comfortable with. Next slide. So there's a variety of different ways, as we said, to give the medicines, and they differ not only in the way they're given, but how fast they work. So intravenous, or giving it through an IV, giving it into a vein, is going to be the quickest. You're going to get the levels up very quickly, and within a minute often have action. The nose is also a very quick way to do it. Usually has action within 5 minutes, as is a sublingual route or under the tongue. If it's given into the muscle through an injection, that's going to take a little bit longer, up to 20 minutes. The rectal route can be very quick, as little as 5 minutes. Sometimes it can take longer. Swallowing a medicine or ingestion is going to take up to an hour and a half, depends on which medicine you use. And finally, the VNS, which we'll talk about at the end of this section, if it works for you, can work fairly quickly after the swipe of the magnet. Next slide. So as we said, there's a couple therapies out there that are FDA approved. One has been out there for a long time. That's rectal diazepam, or Diastat, as it's called, its brand name. More recently, there has been a nasal version of midazolam, or nasal Versed, that has been approved by the FDA, called Nasalam. And so that has been approved. It's not yet hit the market for prescription, but we do expect that hopefully in the very near future. There are a variety of different non-FDA approved medications. So these are medications that are FDA approved. They're just not FDA approved to be used in these ways as rescue medicines. So giving sublingual benzodiazepines of a variety of different types, lorazepam, diazepam, and midazolam are the most common. As we said, intramuscular or subcutaneous versions are also used by some people. There are some medications that are being developed. So again, they're old medicines, but they're just being looked at in a different way to administer them. So buccal diazepam and intranasal diazepam are two of those. And then a new medicine, inhaled alprazolam, is also in development. Next slide, please. So let's go over the different medicines. Rectal medicines we'll talk about first, because they've been around and FDA approved the longest. So there's advantages of this in that they can be given to a conscious or an unconscious person. The medication is rapidly absorbed so that it is effective. If you have a person who has a lot of nausea or vomiting after a seizure, giving it this route avoids the problem of not being able to get the medicine in. And of course, it's safe to use. It has a long track record of being very effective. There are disadvantages. It's not going to be acceptable to all people, right? Especially if you're maybe an older kid or an adult, you're in public. This might not be the desired route to receive a rescue medication. You'd often need someone to give it, and it can be difficult to give in certain people. For instance, people who maybe are in a wheelchair, or a person who maybe after the seizure is more moving around a lot and harder to administer medicine to. It may be a little more difficult. Next slide. As we said, it was the first approved out-of-hospital rescue therapy, approved in 1997. It's used for children and adults, really considered a standard rescue therapy. You're going to see it a lot. Very well tolerated, with really only sleepiness being reported in a significant number. And importantly, as we talked about in the beginning, problems with respiration, so a slowed breathing ability, or difficulty maintaining oxygen saturations are really not a problem with this medication. Next slide. It's quite easy to use, as I said. It's a system that's already ready to use when you get it from the pharmacy. So it is a dialable device that is dialed to the dose that you have been prescribed by your doctor, and it should be locked and ready to use when it leaves the pharmacy. And that's actually an important thing, because not all pharmacists end up locking this vial like they're supposed to. So when you get it, what you want to see is that there's a green band at the bottom that says ready, to know that it is locked at the dose that was prescribed for you and it's ready to use. It's easy because you can store it at room temperature. You can carry it around with you, have one at school, have one on your person, maybe have one at work. Next slide. So it's quite, to use it, basically You have it with you. If a person is having a seizure, you're placing them, of course, on the ground and on their side, generally facing towards you. You expose their buttocks, the syringe, you put lubricant on it and insert it into the rectum. As you push the plunger down, we tell you to count to 3, then hold it, the plunger down, counting to 3. Finally, withdrawing the syringe, holding the buttocks together, counting to 3 again. This gives it time to get absorbed, and then observe the response and follow the rest of the seizure action plan as far as the follow-up care goes. Next slide. So this is a video of Patty explaining the device, so we can play that.
This is Susan's come across her child who's having a seizure. And so she's going to demonstrate for us what she would do in giving the medication.
Okay, I would have checked this already, so I see the green bar. I would have my child on their side, and in this case it would be easier if they're facing me. This is a little stiffer than my child. And holding the diastat, I check the dose, I see the green bar, I'm good to go. I remove the cap, making sure the safety pin is in the middle and has come out smoothly with it. I would rip open the lubrication pack that's also included with the medication. I would dip the tip in the pack, get a lot of lubricant on it. I would just pull the pants down enough just so that I have access to the anus, and then insert the medication very slowly. Press the plunger with a count of 1, 2, 3. Hold the medication there for a slow count of 1, 2, 3. Remove the syringe, holding the buttocks closed. 1, 2, 3. And then pull the clothes back into place.
Next slide. Now, intranasal benzodiazepine, like midazolam, are also commonly used. And the advantages here is they can be given into the nose where there's a very rich blood supply, so they get taken up quite fast, and they're absorbed into the blood, and as a result can work really fast. And in general, they're fairly easy to use, and they're very safe. Now, some disadvantages are that they may require a special delivery apparatus. With the new FDA-approved version, it's going to come in that apparatus and be ready. Currently, the way people get it, it will require an atomizer. So a few more steps right now to get it ready than you use for the rectal diazepam. Some other disadvantages is that at times the medicine can irritate the nose. In some cases, you may need cooperation from the individual to allow you to spray it into their nose. They'll need open nasal passages. And the volumes are limited, right? Because you have to spray this into the nose, so you can't spray large volumes of liquid. So you need a fairly concentrated liquid to give you the response that you need. Next slide. So why does it get taken up very quickly? Well, when the drug goes into the nose, there are a lot of epithelial or skin cells there that are going to absorb it quickly into the bloodstream. You have a lot of blood vessels in the nose. And so it can pick that medicine up really fast, transports it across the blood-brain barrier where it can act on the brain where you want it to work. Next slide. The intranasal midazolam nasolam, which has been approved by the FDA, is currently approved for acute treatment of intermittent stereotypic episodes of frequent seizure activity, such as seizure clusters, acute repetitive seizures that are distinct from the person's usual seizure pattern. And this medicine is currently going to be approved for the use in people 12 years of age and older with epilepsy. It's able to be given by a non-medical person, just like rectal diazepam. Each spray is highly concentrated with 5 milligrams in just 0.1 milliliter of spray. And once you give the one spray of 5 milligrams, if the seizure persists after 10 minutes, a second spray can be used. The side effects they saw in their studies were expected sleepiness, headache and nasal discomfort, runny nose, and throat irritation in some people. Next slide. There are, as I said, other ways to do intranasal benzodiazepines, and currently many people may have this. And basically what you do is from either a compound pharmacy or your local pharmacy, you're getting the liquid IV version Sometimes they'll give it to you in a pre-filled syringe. Sometimes you just get the vial of the medicine. You then draw up the required amount. You switch the cap to put an atomizer on the syringe, which turns the liquid into a spray and then can be given into the nose. So the dosages and the storage of these drugs is going to differ. So you'll need to check the seizure action plan and talk to your healthcare professional about which one might be right for you. Next slide. The sublingual and buccal route are ways we can give medications in the mouth. The advantages of this are these medicines are going to dissolve quickly and also be absorbed quickly because there's a lot of blood vessels there in the mouth that will take up the medication. Often these medicines require no refrigeration and are quite easy to carry around with you and have available. There are some disadvantages. In some cases, there may be some irritation of the mouth. In some situations, especially if you're working with children, they might swallow the medicine. Once you swallow the medicine, now it's entered the stomach, and you're going to have a time of onset that is longer, like we talked about earlier, up to maybe 30 minutes or more. For some people, the taste might be a problem. In some situations, there's some risk of aspiration, certainly if there's an active seizure going on. And if there's an active seizure occurring, giving these medicines is a little more difficult and really not advised because there's a risk of being bitten or injured by putting something in someone's mouth having a seizure. Next slide. A variety of different benzodiazepines can be used this way. Lorazepam, which is also known as Ativan, and again, midazolam, known as Versed, are two very common ones. Some people will also use diazepam, which we've talked about before. Next slide. To give these medications, first of all, when do you do it? You want to do it when you really have a person having clusters of seizures where there's a fairly good recovery of consciousness in between. You don't want to give it to someone who has a persistent loss of consciousness just due to risk of not only aspiration of the medication, but risk of continued seizure and injuring of yourself. When you do administer it with gloved hands and using a gauze pad, you want to just dry the cheek or the gum, place the tablet then in the pocket between the cheek and the gum or under the tongue. You can rub it gently, that helps it to absorb, and then basically observe response and continue to follow out the seizure action plan for that particular patient. Next slide. Oral clonazepam we want to talk about because that is something that people use commonly. There are two different kinds of clonazepam tablets. One is an oral disintegrating tablet where you could give it in that buccal or sublingual approach and let it get absorbed. But there are also regular tablets that are not dissolvable. If you have those regular tablets and you're swallowing them, or you're swallowing the disintegrating tablet, just know that the action time of that medicine as a rescue medicine is longer because it's going to be swallowed into the stomach. So it can take over 20 minutes before it works. So that's could be a completely appropriate rescue therapy if the seizures we're trying to rescue are spread about by a longer period of time where that makes sense. But if we're talking about clusters where the occurrence is much faster, then we're going to need something that works faster. Next slide. Finally, some people have a vagus nerve stimulator that they'll use. The vagus nerve stimulator, for some people, if the magnet is swiped and turns the generator on immediately, and for some people that actually will help them stop the seizures. So that is one other option people will have as a rescue therapy. Next slide. And we'll turn it back over to Patty to finish out.
Thanks, Dr. Perry. So as Dr. Perry stressed, I mean, using rescue therapies needs to be individualized. So that means, everyone needs to be proactive, I think, in really working with their healthcare team. So before using a rescue therapy, you need to know your seizures. So know your own or your loved one's typical seizures and the pattern. And make sure you share that with your team, because if you can have that identified pattern, then they would think about certain types of therapies that you might be able to take your own, versus if your seizures were lasting longer and you didn't, you weren't as aware between them, then a different type of therapy might be prescribed. So you need to know those typical and be able to recognize when it's not typical. And that will help kind of identify that need for therapy. And then you really need to make sure that someone sits down with you and goes over, how do I use it? What are those side effects? What do I need to monitor? Do I need to call 911 or not? And then, as Dr. Perry stressed, I mean, our big message is everybody needs a seizure action plan. So these are two from the Epilepsy Foundation. The top one is one specific to students. The other one with the purple and green border is for anybody. And these are both fillable and are found on epilepsy.com, or if you have my seizure diary, they're available in there. Whatever it is that works for you is what you use. And these are pretty self-explanatory on how to fill out, but there's also a section right on epilepsy.com that teaches you how to use seizure action plans. Next slide. So a very, very common issue is, well, what should I do afterwards? And this comes up a lot, particularly for students who may need a rescue therapy in the school. And in some school districts or states, there might be requirements that if a person has a seizure that needs a rescue therapy, you absolutely need to call 911. Well, and in fact, as we just heard, these were designed to keep people out of the hospital. And so ideally, if they work, what you want to do is provide that you stop the seizure. You really want to provide that care and comfort, give the person time to recover. If they're still not conscious or that they're sleeping afterwards, you want to keep them in a good position, make sure that their airway's clear till they're fully recovered. You do look to see, are there any side effects? Oftentimes people worry about someone being too sleepy or having slowed breathing or what's called respiratory depression. And the sleepiness can happen a lot, and while some of that might be from the medicine, a lot of it's because of the seizures that you're having. And so that sleepiness might have occurred irregardless of whether you gave the medicine or not, but the person may need a place to rest. The slowed breathing is very, very infrequent from the medication at the doses prescribed for this use. And in fact, if breathing difficulties were to occur, they're most often probably due to the problems from the seizures, particularly if people are having repeated seizures. So for all intents and purposes, if the seizure stops and the person's, recovering okay, there is no need for them to go to the emergency room unless in their specific situation, they need extra care. They might be at risk for other problems or have other medical problems that could be exacerbated. So again, that goes back to referring to the seizure action plan. For calling a 911, again, if you're on your own, you're thinking about what are the guidelines for me at home or at work or when I'm at play, again, talk to your doctor or nurse about what happens. These three bullets are kind of typical for anybody. If your seizures continue, or if you injure yourself, or you think you injure yourself, you might have a lot of pain in an area or have whacked your head if you fell. And, if you're not sure, better to get checked out. And again, if a person's not coming back to the baseline, and then if you're not sure, if family's not sure, and they want to get checked out to be on the safe side, it's better to go and to do that, right? But ideally, if that is not the case, then when the seizure stops and they're recovered from the medicines, it's time to go back to their usual activity. Keep in mind, if we're talking about someone in school, it could be that the effect of the seizures leads to problems with learning. And they might stay in school, but they might not capture anything that's being taught to them during that time. So sometimes people might go home to rest because, they're having more cognitive problems or not ready to learn or do what they needed to do. Next slide. Excuse me. There are a lot of other questions that people ask, and I just wanted to pull out a couple of these because we've addressed these over time. I want to stress the question, who can give a rescue therapy? So all of you should talk to your doctor or nurse about, is this one that I can give myself? So if you're using the Clonazepam, under your tongue or between your mouth or your tongue, or an Ativan or any of those medications, you're most likely taking it between seizures or after a few seizures, and is very easy to give to yourself. Or if you're not able to do it yourself, then someone else could be administer it. It's a little harder to give Diastat to yourself, but it can be done, right? How often, okay, so who else can give it? Anybody who's trained in it. And when I say trained, again, you want to make sure that they know your typical seizures and what's atypical, and that they've been instructed on its use. So again, if you're in a school setting, you want to make sure that you or your parents talk to the school nurse about the instructions and what's needed. If you're in a work setting, you may want to talk to a school nurse at the work, or someone that might be able to help you if you need it. You can certainly carry rescue medicines around with you. You've got to keep in mind that there might be special instructions. So the liquid Clonazepam usually needs to be refrigerated, so it needs to be kept in a pouch with like a cooler of some kind. But none of these other ones that are approved need to be. Sometimes people ask if cannabidiol, a medical cannabis, can be used as a rescue therapy, because there's information out there on the internet saying it is. And school nurses get this question all the time. But there is no studies done or any kind of medical evidence that shows that cannabidiol or other forms of medical cannabis would work or have been used and tested as a rescue therapy. Monitoring, I think we talked about monitoring before, and breathing problems, and whether or not you need to go to a hospital. And I guess those are those big 3 bullets that, in addition to the type of therapy, you really need to make sure you talk about those last 3 bullets with the people who know you best. So that's your treatment team, but that's also your friend, your partner, your spouse, or your family that see you during the seizures and see how you respond to a rescue therapy. And I'll turn back to you, Dr. Kyriakopoulos.
A quick reminder to reach out to the Epilepsy Foundation through our online sites at epilepsy.com and End Epilepsy, and to call into our helpline with any additional questions you may have. Remember, your local Epilepsy Foundation offices can also help you link to the best epilepsy care and to build support with the epilepsy community close to your home. This concludes our webinar for this evening. Thank you to Dr. Scott Perry and Patricia Osborne-Schaefer for providing us with their valuable insights. We appreciate all of you joining us tonight, and we hope you'll be back to join us again for more learning on our next monthly webinar, October 30th from 8 to 9 p.m. Eastern Time. Thanks for being part of our epilepsy community of learning.